Good afternoon, everyone. We'll wait a few seconds here to let everyone get in. All right. Good afternoon, and welcome to the Rural Emergency Hospital Educational Webinar and Fireside Chat. We are so excited to have with us today 3 hospitals who will be chatting with us about their REH experience and early learnings. We do have a packed agenda today, so we're going to start out by giving you a brief overview. If you've joined us before, you may have seen some of this information. But if you're not familiar with the REH designation, we're going to go over at a high level the policies and requirements of being an REH. We're going to talk a little about the Rural Health Redesign Center and the technical assistance that's available to all of you. And again, we're going to have a fireside chat. Janice Walters will be leading that discussion. And to close out our time today, I will provide you with some resources and next steps. As always, we want to note that the work of the Rural Emergency Hospital Technical Assistance Center is funded by the Health Resources and Services Administration, also known as HRSA, of the U.S. Department of Health and Human Services. Again, we have with us today Janice Walters, and she is our Executive Director here at the Rural Health Redesign Center. We also have Anna. Anna is the Program Director for the Rural Emergency Hospital Technical Assistance Center. And my name is Amy Kaltenbach. I'm the Project Coordinator here at the RHRC, supporting the Rural Emergency Hospital Technical Assistance Center, and I will be your moderator today. And as an introduction, Janice is a highly rated rural health expert with over 20 years of leadership and healthcare finance experience. She works closely with rural health executives, state and federal programs, and other community partners to ensure rural communities across the United States have access to quality health care. Anna is a nurse executive and a previous critical access hospital CEO. She is a transformational leader and enjoys working with rural hospital leaders to innovatively maximize their impact to the communities that they serve. Before we get started, I just want to go over a few housekeeping items to keep in mind. You may notice that you're all on mute, and this is to eliminate the background noise. Whenever possible, please use the webinar link to log in rather than using the call-in option. This will ensure that you have the best audio quality experience. We also encourage you to ask questions, so please feel free to use the question and answer feature that you'll find at either the top or bottom of your screen, depending on the layout. If you need closed captioning, that's available to access. You'll click the More with the 3 dots at the top of your screen, then select Language and Speech, and choose Transcription for the closed captioning option. The slides and recording from this webinar will be available on our website, rhrco.org, within a week after the event. If you have any follow-up questions, please reach out to us at rehsupport@rhrco.org. And now I'll turn our presentation over to Anna.
Good afternoon, and thank you all for joining us today. As we get started, I'd like to introduce you to the Rural Health Redesign Center and the Rural Emergency Hospital Technical Assistance Center. Our mission at the Rural Health Redesign Center is to protect and promote access to quality health care in rural communities across our country, with a vision to help rural communities thrive through improved health. This work is accomplished through our various programs and work with rural leaders. At the Rural Emergency Hospital Technical Assistance Center, we work to inform interested hospitals on the eligibility criteria, payment structure, and application process for the Rural Emergency Hospital. The REH is a new Medicare designation that was established through the Consolidated Appropriations Act 2021 and became effective January 1st of 2023. And since that time, 30 hospitals have converted to a rural emergency hospital. Our work at the REH TAC is in cooperation with HRSA, the state offices of rural health, and the hospital associations, as well as hospital leaders who express a desire to learn more about what the REH designation would mean for them and for their communities. As hospitals reach out and request technical assistance, we take each participating hospital through an educational process that includes REH-specific requirements, conditions of participation, the application process, and financial modeling to demonstrate the impact of an REH conversion and what that would mean for that individual hospital. At the beginning of the TA process, we match each hospital with one of our provider liaisons or subject matter experts who each have rural relevant healthcare experience. The provider liaisons partner with the hospitals and support them through the TA process, including one-on-one technical conversations during the financial modeling process. Financial modeling, once completed to the satisfaction of each participating hospital leader, can assist with informed decision-making. If a hospital determines that the REH is right for them, then application process support and strategic planning is provided as well. The partnership that began with the pre-conversion process is then continued in the post-conversion program as well. And this also includes one-on-one conversations and continued technical assistance based on each hospital's individual need. The REH Leader Forum, which is part of the post-conversion program, meets every month on the third Tuesday and is open to all REH leaders. The REH TAC offers multiple areas of technical assistance, and that's made available to each participating hospital. The various areas of technical assistance are discussed with participating hospitals that have converted to an REH, and these conversations take place with our regional liaisons. The regional liaisons are strong rural healthcare advocates, and they partner with each hospital as they convert to provide them support and to help them be as successful as they can be on their new REH journey. The liaisons then connect the hospitals with our various TA teams for continued assistance. If you or someone you know would like additional information on the REH and the designation and what that would mean for you and your individual community, please reach out to the REH support line. That's REH support at rhrco.org, and we would love to set up a time to speak with you so that we can help you explore the rural emergency hospital and meet you where you are in that period of discovery. So we're very excited to have the REH hospital leaders with us today. So we really want to get to that part of the webinar so that you can all hear their insights on the REH and what that has meant for them and their communities. So I'd like to take a moment to introduce each of the leaders. Miss Anna Doan is the Chief Nursing Officer at Anson General Hospital in Anson, Texas. Anna began her nursing career in 2002 as a charge nurse at Anson General Hospital and has served as the Chief Nursing Officer since November of 2020. She holds a Bachelor's of Science in Nursing from Hardin-Simmons University, and she is committed to delivering the gold standard of care for her patients. Anna is married and is a proud mother of a 9-year-old son named Derek. Thank you, Anna, for taking time out of your busy schedule to be with us today. Joining her is Ted Matthews. Ted is the CEO at Anson General Hospital. Ted has over 25 years of experience in rural healthcare. He has served as the administrator and CEO of 2 rural hospitals in Texas, both Anson General and Eastland Memorial Hospital. Ted has actively participated on numerous healthcare boards, including TORCH, THA, TRHA, and various state committees, and is very engaged in addressing rural healthcare issues at both the state and national levels. Although Ted retired in 2021 to spend more time with family and friends, he returned to Anson General Hospital on an interim basis to assist with financial challenges and guide the hospital's conversion to a rural emergency hospital. When asked about returning to lead Anson General through the REH conversion, Ted has said, "How could you say no to your home community?" So thank you, Ted, for all you do for rural healthcare, and thank you for joining us today. Frank Tenorio is the CEO and administrator at Guadalupe County Hospital in Santa Rosa, New Mexico. Frank was appointed this position in July of 2024, but prior to his appointment, Frank served as the assistant administrator from 2008 to 2024. Frank has managed infection prevention, safety, risk management programs, and has acted as the emergency preparedness coordinator. Frank held the position of medical laboratory manager since 2004 and is a former chairman of the New Mexico Region 3 Emergency Preparedness Coalition. He is a fellow of the American College of Healthcare Executives and certified in Lean Six Sigma. Frank earned an associate's degree from Luna Community College and a bachelor's and master's degree from New Mexico Highlands University. He is married to his beautiful wife, Elena, with 2 adult children, Angelique and Ryan. Thank you, Frank, for being with us today. And David Waltz is the CEO of Medallia Health in Minnesota. David holds dual bachelor's degrees in nursing and elementary education and a master's of business administration. David is a certified nephrology nurse and a fellow of the American College of Healthcare Executives. David served as senior director of women's and newborn health and director of Centracare Kidney Program in central Minnesota, and former national president of the American Nephrology Nurses Association. Currently, David is the ACHE regent for Minnesota and a board member of the Minnesota ACHE chapter. We are happy to have each of these rural healthcare leaders with us today, and thank you again for taking time out of your busy schedules to chat with us. I will now turn it over to Janice Walters, the Executive Director of Rural Health Redesign Center, for our Fireside Chat. Janice?
Thank you, Anna, and certainly thank you to our colleagues who are willing to join us for this conversation. So if I can have the panelists, please turn on your cameras so everybody can see you. If you haven't already done so, that would be fantastic. So really our goal today is to just have a conversation for you folks to share your journey. Not only are we here at the TAC Center learning from all of you, I like to thank the people that were willing to raise their hand and go first through the assessment process and then the conversion process. So our goal is to, like I said, just have a conversation around this beautiful picture of a fire and just allow you to tell your stories through a guided conversation, again, for the benefit of learning for everyone that's joined us today. So I'm not sure if Anna pointed this out or not. David, you were a hospital that assessed the REH potential, but chose not to convert, where our other 2, Frank and Ted and Anna, are from organizations that did go through the assessment process and make that determination. So our conversation today is really going to highlight both those that did convert, and then the reasons that David and his community and organization felt that maybe it wasn't the right decision for their community. So to start things off today, my question is going to go to Ted and Frank first. How has the transition to the Rural Emergency Hospital designation affected your facility? Has it been beneficial based on what you've seen so far? And I'm going to ask Ted to take lead on this, and then Frank, if you would jump in as well.
Thank you, Janice. Absolutely. So in February of 2023, we had a documentary team here, and they were doing a documentary on us, anticipating that we were going to be the 28th rural hospital to close in the state of Texas. And that was primarily due to declining census, lack of patient volume, and some monumental financial issues. So in January of 2023, we had started the application process to convert to a rural emergency hospital. And the end of March, we received notice from Novitas or CMS that that process had been completed and that we were at that point a rural emergency hospital. So we took the necessary steps. We understood that we were going to be addressing our patient base on an outpatient basis. And we unfortunately went through the staff reductions because we no longer had inpatients or swing beds. And we were able to control costs and expand some other services. But I tell you what, Janice, without that lifeline, without that conversion, we would have been the 28th rural hospital to close in Texas. And we've countered that. People are quite amazed that we are still here. From a financial standpoint, we're doing much better. The facility payment has been monumental to us, and we have a future now. So without that conversion, we wouldn't be, Anna and I wouldn't be sitting here right now.
Thank you. So Frank, how has it impacted your community, and has it been beneficial so far?
Yeah, so we transitioned September 1st of 2023, and since then, it's definitely had a positive impact on my community and my hospital. We partner with an FQHC lookalike that's located within our building, and they do a really good job of chronic care management. And prior to our transition, they were, they were managing patients on an outpatient basis, patients with COPD, diabetes, CHF. And they did a really good job of managing these patients, so we weren't seeing the admissions for these patients anymore. But at the same time, we were also seeing our emergency room volume increase. It started to spike. So it's really very important that we do receive the facility payment. It's had a positive impact on my facility, and it's given us a sense of relief rather than a sense of worry about inpatient volumes or decreasing inpatient volumes.
Thank you. So David, you went through the process and you didn't come to the same conclusion that Ted and Frank did for their facility. So can you provide some insight into why the REH conversion wasn't the right decision for your community?
Yeah, thank you. And thanks for the opportunity and good afternoon, everyone. So when we really thought this was going to be our saving grace as well in Vandalia, Minnesota. Our daily census, average daily census is about 2.7 patients. That's observation, swing beds, or transitional care patients, as well as inpatients. So only 2.7 patients. We really thought this was going to be our saving grace as well. Seeing our EBITDA and our net income not where we'd want it to be in the last couple of years, being $1.5 to $2 million negative, we knew we needed to do something differently. And when this was presented to us, we thought this might be a good opportunity. When we explored it further, we have 2 nurses on at any given time, taking care of both ER patients, ED patients, as well as our inpatient swing beds and observation. And so in our evaluation, we did not think safely that we could reduce our staffing levels in the hospital. And so when we took that into account, no reduction in staffing, coupled with decreased reimbursement for our surgery patients and other items that we're performing at the hospital and our clinics, we felt because we would have to then switch from a critical access hospital, which is cost plus roughly 1%, to a PPS model and plus 5%. That was a reduction in about $2 million to our bottom line, and that's on top of the subsidies that would have been coming to us through the REH. And at that point, just financially, we couldn't make it go.
So for those of us that have a financial background, we would say the math didn't work for your organization.
Spot on.
Yeah. So just to clarify, Frank, you're there in Guadalupe. You're a PPS hospital, and that's also true of Ted. Correct? There in Texas, you were both PPS hospitals. Correct?
That's correct.
That is correct.
Yeah. Yeah. So Frank, I'm going to come back to you with a question. So you've already touched on it a little bit as part of your opening statements there, but how has your clinical care changed there at Guadalupe? Have you seen any changes? If so, what were they? Or on the flip side, if there haven't been changes, what's attributed to that as well?
So I don't feel that our clinical care has changed at all. I believe that the quality of care that we provided prior to our transition is the same quality of care that we're providing at this point. Essentially, for my hospital, the clinical care was the same. Excuse me. The only difference is that now that our clinicians, we ask them to initiate a transfer process if they anticipate that a patient's going to require an extended length of stay or a higher level of care. There are times when our physicians contact other facilities for transfers, and those facilities are exceeding capacity. They might be at 120% capacity. And so we ask our providers to document in their notes, a clear documentation that they have initiated a transfer, but there was no bed availability. So clinically, nothing has changed. Logistically, it has changed a bit, just as far as initiating transfers.
How did your clinicians respond to the changes that you asked them to make? Any issues there?
No issues. They responded very well.
Right. So Anna, I'm going to pull you into the conversation now. So obviously this is a big decision for any community to make. But how has your community responded to the overall changes there? I know you've been with the organization a little longer, maybe than Ted has, and so have that historical viewpoint. How has your community responded to the new designation?
I do think at first that the conversations were very uncomfortable with the community, just thinking that in their mind they had lost healthcare because we had to, explain about the loss of inpatient and swing bed. But over the last, 10 years, our entire county of 17,000 had 3 hospitals, and 2 of those hospitals closed, leaving us the one hospital within our county. So approaching it as the patients, the county still had access to healthcare made that conversion a lot easier. Patients had understanding that they still had access to an emergency room, they would still have access to be transferred. And the more they utilize the services and utilize observation services, the more reassurance the patients have. And like Frank said, the quality of care never changed.
Very good. So I'm going to throw this out to all 3 of you. You can take turns on who wants to jump in and go first. But how did you involve the community in the journey? So, obviously, as we work with communities across the country, this is a very sensitive issue at the surface. If you think about having to give up inpatient care, all of that. So how have you engaged the community on the journey? Did you engage them? Didn't you engage them? What was the approach that each of you took?
So I'll go ahead and go first. So essentially, we notified our community that we were making the transition to a rural emergency hospital. And we assured them that the care that they were going to receive was going to be the same, even though we were transitioning to a rural emergency hospital. We just notified them that if we anticipated an extended length of care or higher level of care, that they would be transferred to another facility. The community in Guadalupe and Santa Rosa, they really have confidence in our hospital, and they have trust in us that we made the right decision by transitioning to an REH.
Fantastic.
Okay, Janice, we basically did a soft needs assessment and spent the time with our community members, those individuals that would come to our board meetings, etc. And probably the loss of inpatient, again, we're the only hospital in the county, so should you have to go somewhere on an inpatient basis, it's about 30 miles away. And so that was uncomfortable to our elderly or geriatric members or residents. So it wasn't so much on the inpatient side that we had the pushback. It was more on the swing bed side or the SNF side for us. And we had lots of questions on that. Anna, you were there at part of those meetings. And
I think the loss of long-term care facilities have made that difficult too. When several within our county shut down nursing homes. And so swing vet is what those patients relied on. So I think just reassuring the community that we would help them in that process of finding them, a SNP unit or wherever they needed after they had to have a surgical intervention or whatever they needed to require skilled nursing. But that has been the most uncomfortable conversation with the community.
Right. We lost our nursing home. We do not have a nursing home in our community. So for those individuals that return to SNF or a skilled nursing facility, it's about 20 miles away in either direction for them to go. And again, dealing with a geriatric population, just the mere fact of driving from point A to point B, then back to point A can be an obstacle.
Okay. So before I turn it over to Dave, can I just ask one question there of Ted and Anna, Dave? So as an REH, you are able to open a distinct unit, a nursing unit. Can you talk through why that wasn't feasible for you folks real quick?
Absolutely. In fact, we looked at that on a state basis and had 2 architects come in and understand as a result of that, we had to meet current life standard codes. And just one example, we are a 72-year-old facility here. So our halls are 7 feet wide instead of 8 feet wide. And then we had some other hurdles that we just could not get over. So from the state licensing standards standpoint, we did not qualify. It would have been a major renovation project. And in fact, it just wasn't feasible for us.
Thank you. So David, sorry, thank you for indulging me with that one follow-up question. So David, how did you engage your community on your journey?
Yeah, we engaged our board, which is a representation of our community. We did not bring it to the community for any discussion and or input. This was on the tail end of transitioning out of home care. And so the community was a little upset that we no longer offered home care in our communities. We partner with other organizations to bring that care to their homes. We can't do everything in our community, unfortunately, and we were losing about $500,000 a year just on home care. And now all our clients or patients do have coverage for home care, and the employees. Half of the caregivers actually still work for us. The others that truly loved home care did get employment elsewhere. And so we decided not to engage the community for those reasons.
Fair enough. So coming back to Ted and Anna, what are you experiencing anything as an REH that maybe you didn't expect? Are there any surprises for you post-conversion?
I don't think there have been big surprises. It's just back to the same, questions that the community always says, or questions like, are y'all ever going to go have a real hospital here? And just reminding them and reassuring them that they still have access to care. These other communities that have had to shut down, they have no access to care. And now this still provides our community with access to care. And that has been the most, I feel like, I didn't think those conversations were going to be as uncomfortable. Just as someone who is very active in the community for several years as I've been, that has been the most difficult thing that I was not expecting.
And one thing we did, Janice, is that we're very aggressive on the observation side. And so as our community comes in and understand we have about 250 ER visits a month, and we transfer 30-ish or so on a monthly basis to a higher level of care. But we are able to keep a number of those ER visits or those ER patients encounters for at least a 24-hour observation stay, or sometimes longer than that if we have trouble transferring somewhere. And, that has kind of reassured our community. lots of times when they come in, they don't quite understand the distinction between an inpatient or an observation patient. We treat them the same, of course, and meet their clinical needs. So what was a little bit of an alarm at first has subsided some point. And there are actually a couple of instances where we've kept our observation patients 48 hours. Now, we do know this is all bundled in the APC, but it's just good patient care. And so we're willing to do that.
Yeah, and that's an important point because your average over the length of a year can exceed 24 hours. So there's
Right.
certainly going to be times where patients can stay longer and some will stay shorter.
Right.
So Dave, coming back to you, so you didn't convert, you're still a critical access hospital. What's your biggest challenge in your current state?
Our biggest challenge is bringing in cash. We converted to a new EMR, and our AR rose, and it's right now gross AR is a little over $9 million, and we're nearing timely filing, et cetera. And so we've now outsourced our rev cycle department, coding, billing, and collections, and hopefully those efforts will improve our bottom line. So that's the biggest thing, that we need to really bring in the money that's out there. And as well, as I mentioned earlier, our daily census is 2.7. We're really partnering with other hospitals. How can we actually accept patients that are appropriate for us in a smaller critical access hospital to get over 5 patients at any given time in our hospital? Lastly is controlling expenses as much as we can. We're negotiating all our contracts. We have entered into a high value network called the Headwaters in Minnesota. It's right now it's a compilation of 19 other small rural health facilities that collectively, rather than say $35 million of gross revenue, you put us all together and we're a little over $1.5 billion. And so hopefully with shared best practices, we're clinically integrated, we can not only improve our quality, although our quality metrics are outstanding, but then how can we leverage our size to get better outcomes, both financially and cost effectively.
So I'm going to pick back up. Thank you for that, David. I'm going to pick back up on something that Ted said a little earlier, and just give folks the ability to comment on the age of plant, physical needs, all of that of your facilities. Are you struggling with, even within the REH state, you're struggling with age of plants, capital needs, all of that? Anything there that is noteworthy from your perspective as both REH leaders, as well as then David, you still as in the CAH state?
Yeah, I can start. Our facility plant is getting older. We're over 60 years old, and the ED and where the ambulance base comes in, you've got to push the gurney up an incline to get to the emergency room, and so it's not laid out perfectly. And there was some architectural drawings and renderings performed about 3 years ago, and it was just cost prohibitive. And so capital dollars are very hard to come by. Fortunately, we write a lot of grants, and sometimes we get awarded on some of those smaller items that we can meet some of the capital expenditures through grants, because our margins just haven't been there to support it.
Ted or Frank?
So we have a fairly new facility. We've been in our facility for about 13 years. Our plan ops director does a very good job of the upkeep in our facility. I think the maintenance is where we see cost, maintenance in HVAC systems, maintenance in plumbing, and capital. Right now, we're looking into purchasing new lab equipment and new radiology equipment that is becoming obsolete at this point. So that's what we're seeing right now as far as our costs are concerned, is really obsolete equipment.
Ted, anything you'd like to add?
Yeah, just briefly, yes. As I mentioned earlier, we are a 72-year-old facility. And so infrastructure is a huge issue, not only at our hospital, but throughout the rural hospitals in the state of Texas. I mean, at some point, you're going to have to address that. There is no possibility of new construction for us. We just do not have the funds or the revenue or the sources of income to do that. But what has helped us is that obviously leading the nation in the closure of rural hospitals is not a checkpoint that you want on a national basis. So the state has wrote out a lot of grants for us. And these grants address debt, they address capital expenditures, et cetera. So we are extremely aggressive on the grant side. And in fact, at times, our operations are fully subsidized by grants that we're receiving. So it's allowed us an opportunity to build up our cash reserves and to move forward. Once again, we're expanding some care, but that's the 800-pound gorilla in the corner. At some point, we're going, what do we do at that time?
Great, thank you. So Dave, I'm going to come back to you with this question. So you've went through the assessment, you determined it wasn't right for your organization. What if you could change anything about the REH statute to make it more feasible for your organization, what would that be?
Yeah, first of all, keeping the payment structure as critical access plus critical access, so cost plus, rather than transitioning to the PPS plus 5 or now 10%. I think number one. Number two is to include swing beds in the REH would provide much benefit, not only to the community and the patients that we serve and the people and the population that we serve, but I think it would help alleviate some of the pressures that families have to seek swing bed or, skilled nursing therapy services elsewhere. Thirdly, I'd mention is the 340B, if that could be kept intact for an REH, that would definitely be beneficial to us and our bottom line. And then, I think to better know what the cost report impact of transitioning to an REH would be needed as well. And so those items come to mind that if I had a magic wand, I think we would get close to then having a better analysis of if we should transition to an REH to keep the beds or to keep the hospital open for those emergencies. And so we've provided life-saving measures, and we know that we have testimonials from patients that if they had to drive, another 30 minutes, they wouldn't have been here today because of a widowmaker or a severed arm from a farming accident, et cetera. And so how do we maintain the access to the ED yet to make sure that it's actually cost neutral and or a little favorable to make sure it's sustainable?
So Ted and Frank, I don't want to cut you out of this conversation. Is there anything else? I mean, you're obviously REHs, you're functioning, it's proved very beneficial to your organizations. Anything else that you would add though to what you just heard from David?
I would like to say, David, amen. You're preaching to the choir right here. On the advocacy side, absolutely, 340B and swing bed, critical. And we're working on that. We hope, we believe the REH will evolve just as critical access evolved 24, 25 years ago. And I believe those are the two game changers right there, especially when we send our patients to a higher level of care and they have hip surgery, they have knee surgery, and they need to come back to rehab. We can't accept those patients. And again, we have no facility around here that can, and we have to transfer them 30 or 20 miles away. And we can't free up the bed to the receiving facility either. So those are big issues for us, but swing bed to us would be a game changer.
And just to echo a little of what Ted and Dave were talking about, some sort of a patient admission would be great because a lot of the times our providers are initiating a transfer, and the accepting facility cannot accept our patients because they're exceeding capacity. And so if we were able to admit this patient for a couple of days, that would definitely be helpful. The other point is end-of-life care. If we could admit a patient when they're experiencing end-of-life care, we don't want to transfer a patient who is in an end-of-life care. At our facility, we have a special room that we put patients in where the family can go in and be with the patient in their very last days. We want to make that patient as comfortable as possible rather than maybe transferring those patients out.
Thank you. And I do know for our audience that's listening, we will soon be wrapping up, and we are going to try to address some of the questions that came in through the Q&A. But if you have questions for our panelists, please use the Q&A function, and we'll be getting to that portion of our agenda here in a few minutes. But just to wrap things up, a couple more questions. So, Ted, I know we didn't engage with you early on because it was desperation, really, that made you assess the REH. But, so for some of the other folks, we've been able to engage and provide technical assistance. So can you speak to a little bit about, how has the technical assistance that we've provided you through the RHRC and the REH Tech helped you on this journey? And is there anything in particular that stands out to you as it relates to the technical assistance that you've received? So Frank, we'll start with you.
Yeah, so the Technical Assistance Centers, they have been rock stars. I really enjoy working with them. They put on educational symposiums every month. The first one that I can recall was on a survey process. There's also been some on billing and coding, and the last one I believe was on financial indicators, which is really great. If I can't attend any of these educational symposiums, I'm always making sure that somebody from my staff can. And there's always a recording available if nobody can attend these symposiums. They're really great. Also, right now we're in the process of preparing for a mock survey. This has been huge. It's been really beneficial for us. My intent of the mock survey, I want my staff to be as comfortable and at ease with the survey as possible. So when we do get a survey from the Healthcare Authority of New Mexico or the Department of Health, my staff are familiar with the process, comfortable and confident with that. Lastly, the grant team have been great. I'm currently looking into new service lines for my hospital, and a lot of these startup costs are fairly expensive. The grant teams have really pointed me in the right direction on where to seek out funding.
David or Ted?
Well, I can jump in here quickly. To me, probably it'd be the monthly peer network meetings that we have where we discuss best practices, and we learn from those. Many times Anna and I are sitting here saying, that's a really good idea. We need to start doing that, not doing what we're doing. And also the assistance that you have helped us with on our policies and procedures, and basically just kind of held our hand on this journey for the last year and a half. Even to the point that your office came down to Anson, and we had a number of hospitals here. So it's just the dialogue and knowing that we can reach out to someone when we have those questions, as we do quite frequently. And I appreciate everything that you and your staff have done for us.
Well, thank you. David?
Yeah, and I would echo what Ted and Frank have mentioned. The team, the assistant team, very knowledgeable, accessible. They walked us through, the timelines and the steps, and really provided the education we needed up front. And it provides education that in the future, if we at some point may need to relook at this through a different lens, and so really appreciate their expertise in the process.
Great. So this question goes out to all of you. If there could be some hospital leaders on the phone, or folks from the state offices that are working with hospitals, what would your advice be to anybody considering this designation?
I can start. I think it's a good process to go through, and if you're at that point, rather than potentially closing the doors for a community. And, I heard a statistic for a critical access hospital in a town, it equates to about 2 Walmarts, the economic relevance. And so it's important. It's important for care. It's important for the community. And so take a look at this. This program could work out well for you. The other statistic I heard, there's, 700, hospitals near or near bankruptcy and potentially closing. And so how can we maintain, some of these to remain open to provide those services close to home?
Frank, what would your advice be?
Yeah, so if your hospital has already performed the financial impact study and it makes sense to transition to an REH, I would say flip that switch. Definitely made sense for us. The REH designation for us was definitely a slam dunk. It has continued to allow us to provide accessible care to our community. And really, just because of the REH, we remain financially sound at our hospital, and the community is not worried about, us having to maybe potentially close the doors one of these days. Because of the REH, I would have to say that we would only be open for maybe a couple of years without that facility payment that we receive.
Great, thank you. Ted, what would your advice be for somebody that might be considering it?
I would definitely do the financial analysis, that piece of the tool, that assessment. For us, we had done it, and if we had not converted, our hospital would be closed. Again, we wouldn't be having this conversation. We're the only hospital in the county, and so that would create bad outcomes for most of our residents, just simply because of the distance that have to travel for care.
And if I may, I wish that same analysis would have held true for Medelia Health. If we would have converted over, the analysis showed us that it would have been actually additional $2 million loss for us, and our doors probably wouldn't be open today if we would have converted. And so that's why, the swing bed revenue, if we can maintain that, the 340B, some of those other things that we talked about, to make it financially solvable for community hospitals to remain open in some form or fashion is important.
And Janice, for those listening out there is that opportunity, especially on the swing bed piece of it, whether you're critical access or PPS, and how you blend those rights. Not only is it helps us financially, but it provides, again, that care to our community that's needed. Mm-hmm. It can be done.
Yeah. Well, that concludes the formal Q&A, our conversation, our fireside chat. There was one question that did come in through the QA that I'm going to throw out to you folks because it's for you. And then we are going to move into some of the other questions that came in as part of the registration. I'm going to address some of those. But the question that came in is, have any of you, so this would be Frank and obviously you, Ted, have any of you seen a significant reduction in the ER volume since conversion?
Not for us. It's kind of one of those things, you build it and they will come. We transitioned and they came. Our volumes, ER volumes, have definitely spiked, definitely increased. We were seeing about an average about 220 patients in our ER since our conversion. That has definitely increased to about 260, and it's climbing.
Anna?
Our numbers have stayed consistent in the emergency room. Our numbers were very low when we were PPS regarding inpatient and swing bed numbers. Like David was saying, like it was never over 2 patients average per day. Our goal, we are averaging about 25 observation admissions a month. And I think effective communication with your providers from your rural health clinic and your ER, knowing the services that we can provide and maximizing those services, but it has not affected our ER numbers. They have not decreased.
Right. So with that, thank you all so much for taking the time. We'd love to interact with you. We feel it's our calling here at the RHRC to support rural hospital leaders such as you, and truly to count it a privilege to be able to walk with you on this journey. So thank you again, not only for, like I said, going first, or at least doing the assessment to see if you should go first, but just again, thank you for that. And with that, I will turn this back to Anna and Amy to take some QA and next steps.
Thank you, David, Frank, Anna, and Ted. So we're just going to move on to some resources and next steps, and then Anna will address your questions that came in through registration. So as I mentioned earlier, these slides will be made available to you, and included here are some resources and links. We've consolidated a few things we thought you might be interested in exploring. And again, this is just a reminder, but we will be putting out the recording of this webinar in the next week on our website, and you'll be able to access these slides. So at this time, I'll turn it over to Anna so she can answer some of the questions that came through on registration.
Thank you, Amy. There were a few questions that came in. One that did come in last, and I'll send this out to Frank and Ted also to get their input on, but this includes a question about ambulance transports across present boundaries for needed transports, and how can that be assessed when no local ambulance is available? I'm not sure if either of you have any insight into ambulance transports and how that has affected you as an REH.
Anna, we can answer that. I'll let Anna, our Anna here in the hospital, answer that. She deals with that daily.
For us, I mean, prior to conversion, I don't feel like that has affected us at all. We have our ambulance services with the city, the county, and the hospital district. We only have basic EMTs on our ambulance, so transfers can be difficult at times, but that difficulty existed well before conversion to REH. We do receive ambulances from all the other towns within our county that do not have hospitals, and some of those ambulances do have higher level of care paramedics on their units, and we are able to utilize those for transfers as well as the helicopter. I don't know, Anna, if that's answering the question.
No, thank you for that input. Go ahead, David.
Yeah, I was just going to piggyback on that as well. Most ambulance can cross lines. You can set up mutual aid contracts, and I think that's what the question is getting to. Regardless if you're an rural emergency hospital or an existing critical access hospital or PPS hospital, you can go cross lines if those mutual aid contracts are set up, and people can help each other out. But it's what's best for the patients.
Thank you, David. Another question that came in was regarding any updates on the state of Florida. Florida did pass legislation to allow the REH. So that is on the books. I believe that bill number is 2024 or 644, excuse me, passed in 2024. So that was a question that came in. There are questions about swing beds and 340B being permitted in the REH, and as you've already heard from our speakers, that is not permitted right now in the current statute. There were some questions that came in about the possibility of that changing, and I will just say there's legislation out there that's been proposed that would, if passed, allow some changes to the statute, but again, that is not permitted right now. There are questions about Medicaid and the payment of REHs, and the National Rural Health Association did send out some information yesterday. States will need to work through their state plan amendment process related to the rural emergency hospital and their payments. Other questions? I think those are the majority of the questions that came in. I have an additional question. I heard you talk about partnerships. And I just wanted to ask, how important are partnerships for you as an REH? And do you have a strong partnership with someone or an organization that you think has been very beneficial since your conversion, or a partnership, maybe a future partnership that you're working on that would help strengthen your existence as an REH?
We do. We have basically are transferring the large hospital that we transfer 95% of our patients to. They understand that we're a rural emergency hospital and that there are those times that it's critical that we get those patients transferred. And they are working very well with us. And so when we need to get that transfer, they will step up and accept those patients.
Thank you, Ted.
So we have a long-standing partnership with an FQHC lookalike that's within our building. And so it's very convenient for patients as they come in. They can come in and see their providers at the FQHC, receive a lab order, a RAD order. We also have a retail pharmacy within our building, within our hospital, so they can even get a prescription and fill their prescriptions. So it's really convenient for patients as they come into our hospital. I think it's really a symbiotic relationship with our FQHC. And they've been great partners with us for a very long time.
Thank you, Frank.
So Anna, one question, and I know Frank mentioned it a little bit earlier, and I think you might have some information to share based on a recent conversation. It's about hospice and guidance for hospice patients. So that was another question that did come in. Can you speak to that quickly?
Sure. We have asked CMS if REHs can provide hospice care. The answer is hospice, they can in an observation bed, but the length of stay for that patient would be included in the annual average as well.
So you can't bill specifically hospice, but you could bill observation.
Mm-hmm.
Is that fair?
Yes. Yes.
And then really quick too, I see there was one question that came through as it relates to distance requirement and the ability to convert back. And so there is no distance requirement. Critical access hospitals, so that there's a 35 miles, all of that doesn't apply. And there is a path back if you're a critical access hospital and you convert. There is a path back, but it's important to note that to convert back to either a critical access hospital or a PPS hospital, whatever you would want to go back to, in order to qualify for that, you have to meet current COPs for that designation. So it is acknowledged that does create a barrier for some folks. Because either an old plant or some waivers and all of that. But in order to become that prior state, you would have to meet current COPs. And it's also, there is not necessarily a path back for a critical access hospital that was, I would say, necessary provider CAH back in the day, because you have to meet current CAH requirements in order to become a critical access hospitals. So I just wanted to address those. I did a quick scan. I think we got all the questions, Anna.
There's one more, Janice, and it is, our REH is subject to the Internal Revenue Service Community Benefit and China Accountability Guideline. That is covered in our FAQs, which is on our website, but the IRS requires non-for-profit tax-exempt healthcare facilities to demonstrate a community benefit. So it is recommended that each hospital consult the specialized education program offered by the IRS exempt organization to understand your tax responsibilities. So thank you very much. If there are any other questions, I know there were a few submitted questions from individual hospitals that I've reached out to via email, and if you have not gotten a response, you will. So thank you again for attending today, and I'll hand it back to Amy.
Thank you, Anna. If you're not already following us on social media, I encourage you to do so. We routinely post information that's not only relevant to rural communities in general, but more specifically to the rural emergency hospitals. You'll see our website here, and you're welcome to reach out to us at any time if you have questions. We'll be following up with a survey link via email shortly after this event ends. We encourage you to participate in that survey as we value your feedback on how we can continue to serve you and answer your questions. I want to extend a huge thank you to our CEOs for their time today. We know your time is very valuable, and we are so happy that you're able and willing to share your experiences with us. And thank you to Janice and Anna for your continued work in the rural health space and for sharing your expertise with us. Thank you, everyone, for joining us today on this webinar. We look forward to seeing and hearing from you, and I hope that you all have a great afternoon. Thank you.